Hello, friends. I'm Dr. Ambrish Mithal, currently working as Chairman and Head of Endocrinology across the Max Group of hospitals. Today, we'll be talking about diabetes management in 2021. We all realize the importance of good control in diabetes. The UKPDS showed us many years ago that if we control diabetes well at the beginning, then we get a legacy effect, which means that if you are well controlled for the first few years of your diabetes, long term complications are reduced, including probably macrovascular complications. Therefore, it is important to control diabetes well from the start and not follow a step ladder approach by which the diabetes escapes every time and then we try and control it. So, this is point number one. We need to control diabetes aggressively from the time the patient is first diagnosed. How should we do this? If one had to choose diabetes medicines, one could have a wish list. A few years ago, this wish list would have sounded outlandish and unreal. But we know in the last few years that molecules have appeared which help us to fulfill many of our wishes with regard to diabetes medication. Because it's not just the lowering of glucose that counts, it's the reduction in complications that's important. So when we look at a wish list for diabetes medicines, we are looking at medicines that will lower blood glucose. They should do that without promoting weight gain, and possibly if they induce weight loss, nothing could be better. And they should do this without producing hypoglycemia or low blood sugar. And of course, in addition to that, if they could prevent long-term complications related to the kidney or the heart, that would be a very important added bonus for these drugs. Now, over the last few years, we have molecules belonging to the SGLT2 inhibitor group and the GLP-1 receptor group, which actually do several of these. They do control diabetes well. They're potent drugs. They lower blood glucose without producing hypoglycemia. They help or promote weight loss. And they actually significantly impact the occurrence of renal complications, cardiac complications. Numerous studies have shown us that, and we know that the MPAREG, of course, was the path-breaking study in this. In addition, when we are treating diabetes in India, we talked about early control and we talked about choosing the right drug. The other important point is that we have to deal with a lot of young type 2 diabetes. People who are in their 20s and 30s and they develop diabetes, quite frequently we see that in the OPD. These are typically obese patients, typically with strong family history, and they have to go through life, through many, many years of life with diabetes and with its comorbidities. So for them, good control from the very beginning is really, really important. And along with the other sort of features that I outlined, the other benefits, you have to consider using drugs even more carefully in these young patients. So I'm going to talk about a similar patient, a 38-year-old MNC executive who has a complete random lifestyle, if you will. He doesn't sleep properly at night, he works late, he gets up very late, he eats, orders food from outside, a typical Delhi, Gurgaon kind of patient, young patient, works very hard, but very little physical activity. Now, this gentleman is 38 years old. He has already been a diabetic for last 9 years, which means he got it at the age of 29. As I said, not unusual. He has a family history of diabetes, coronary artery disease, lifestyle I already told you briefly. He's a smoker, so that of course doesn't help. He has gastritis, and I'll come to that, the connection to choosing therapy. And he has been on topical steroids for some skin condition. And the key point here again is that he's only 38 and his body weight is 112 kilograms. So his BMI is 35.8. This patient of ours is on metformin 1 gram twice a day. He has gastritis, I told you. He has an A1C of 8.3. Now, how do we approach this patient? What should we add in terms of by way of treatment to help him out? Should we continue with metformin, give him lifestyle advice? probably it won't work. Sulfonylurea, yes, we can add sulfonylurea, but it can produce hypoglycemia. We all know that. We can definitely add a DPP-4 inhibitor, which is a very innocuous kind of molecule, uh, like a linagliptin, and will lower the glucose somewhat, but will never bring it to target, and is weight neutral, won't promote weight loss. Pioglitazone will also work, but it will promote weight gain, so that's also out. So pioglitazone and sulfonylureas will promote weight gain. DPP-4 inhibitors will not be powerful enough, perhaps, and then we are left with GLP-1 RAs, which the patient doesn't want any injectable therapies. And then we come to SGLT2 inhibitors, which are oral therapies, and which actually should be able to perform all these tasks of lowering blood glucose without hypoglycemia, promoting weight loss, and also preventing or reducing long-term complications. But with an A1C of 8.3, it is possible that adding just a simple SGLT2 inhibitor as a single molecule may not suffice. Therefore, the idea of combining an SGLT2 inhibitor with a DPP4 inhibitor is actually a great idea in such a patient. So what I did for this patient, given his weight, his family history, his it's still early diabetes, it's 8-9 years, but he's only 38, so we really have to look after him very well. I think he's a great candidate for this combination of DPP4 and SGLT2 inhibitor. I would like such a patient to have an A1C of below 7, more like 6.5. And to do that, I think a combination of drugs will be necessary. So therefore, what I did for this patient, especially if it's a fixed combination, because then what happens is a fixed dose combination will actually make his compliance easier, because we know that he's generally a sort of has a poor lifestyle and is not a great, highly compliant patient. So therefore, it makes a lot of sense to add to the metformin a combination of DPP4 and SGLT2 inhibitor, especially if it's in a single tablet. That makes life so much easier for him. And of course, we know that empagliflozin has always been the leader in this. So empagliflozin linagliptin combination is a fantastic add-on for this patient. And it does one more thing. It allows us then to reduce the metformin slightly, because he's getting a lot of gastritis. And therefore, what I did for this patient was I added Empa-Lina combination, reduce the metformin to 500 BD. It's a potent combination that will help him in all the parameters that I mentioned. So the reason I'm highlighting this is that we are talking of relatively younger patients. We are not waiting for patients who are very high risk for heart disease at that point, or have already developed some degree of proteinuria. We are not waiting for that. We are really looking at patients who are relatively early in the course of disease, and that has been the change in SGLT2 in the last few years, that they have climbed up the pecking order to be introduced at an early stage, and particularly when they are combined with DPP4, there will be additional benefits in terms of potency, and there is no interaction between the molecules. So, which is why I chose this combination for this patient, and he's actually doing very well after starting therapy. So, my take-home message for you is that use drugs which will lower blood glucose and give additional benefits to the patient without causing problems, without causing hypoglycemia, without causing weight gain, and at the same time help in preventing long-term complications. And using fixed dose combinations has been shown so many times, and is known very well to improve compliance. And therefore, using two such molecules together makes a lot of sense in the clinical setting. I hope this podcast was useful for you. Thank you.